ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. I am so excited about today's episode. It is a friend of mine, a colleague of mine who works in the dermatology world, but she's a fellow CEO of a very large 17-location independent dermatology practice in Kansas. So it's Tara Gillespie, and we talk about everything from growing. They started with about 5 locations when she joined the team as a nurse practitioner. She actually started out as a medical assistant, worked her way through as a nurse practitioner, became the COO, and then migrated into the CEO role. We talk about how the practice acquires other locations, how they handle succession planning, how they integrate cultures with rural Kansas locations and larger Kansas locations. We talk about structuring partnerships, and then we actually bring up normalizing the business side of medicine, which I really loved, and it was a really unique perspective. Tara Gillespie, welcome to Working Healthcare.
Hey, Meredith. It's great to see you.
It's great to see you. You and I last hung out at MGMA, and you and I have been part of one of my favorite meetings within a meeting over the last couple of years, and it's the MGMA CEO Summit.
Agree. It's the best time. It gets tons of people from all different domains, like your rheumatology, I'm dermatology, but we all share the same day-to-day frustrations, successes, and it's always a good time.
It's always fun, but I've noticed, I don't know if you noticed this year, there were actually more women than there were the previous 2 years because this was our only the third year we've done it. But do you notice like there are a lot more men sitting in the room as CEOs than women?
Oh, yeah. Yeah. But I am liking the change that we've seen over the years. Like, I think you and I probably first, gravitated towards each other. What was that, 3 years ago?
There were like 7 of us, right? 7 women.
Yeah, because we're like, okay, who's the other chick in the room, right? But I feel like this year it is changing a little bit. It's slow, and it's definitely still disproportional, but we're showing up.
And I also think you and I and other people would say, well, back in your day, but you're younger than I am. But I also think that the majority of people in that room are older too. So we both bring the estrogen to the table, and we also bring a little bit of the youth when we talk about the CEO world.
That's right.
So, but you started out on the clinical side. You're a nurse practitioner and went into the CEO role. Why did you even do that transition?
Yeah, I honestly, I don't know. Like, I can't pinpoint it to one thing. I even started further along in the clinical side, at least here at Heartland. So I've been in dermatology here at the same practice for over 20 years. And I actually started as a medical assistant in a part-time job role when I was in nursing school. So I was in nursing school and I was looking for a part-time job. I got a part-time job at the hospital, got a part-time job in a clinic, and this was the clinic. And I just really liked it. I liked the clinic-based medicine. And so I stayed on when I got out of nursing school, and then, went back to school, stayed on as a nurse practitioner, and then, have found myself in the CEO role. And I don't know exactly how it happened. I think I tend to lean into problems and like to fix them. And so I think that's part of it. I also have just been here a long time. And so I know the practice itself of dermatology pretty up and down. And so it was kind of a natural next step. And I was just fortunate to work with our managing partner who gave me lots of opportunities to fix problems, right? Like if I came and said, hey, this isn't working, it was okay, so go fix it. And I was like, okay, I will. And here we are.
Don't you think, though, it's 2 different sides of the brain? If you're a clinician and you're going the clinical route and then you jump over onto the admin side, I say this often with my husband. I'm like, yes, you stay in your lane, I'll stay in mine. But you're in both lanes.
Yes, it definitely is two different mindsets. And I think, so just a little bit of background that may be valuable or not. When I first was in college, my first degree was actually accounting, which I switched real quick because I am a numbers person and numbers kind of come naturally to me. But I was in all these accounting classes thinking, oh my gosh, this is going to be so boring. Like, I can't do this the rest of my life. I have to do something like interactive with people. And so I quickly switched, but I still had that, kind of just natural accounting numbers brain. And then my parents were actually small business owners, not in healthcare at all, but they were small business owners. And so I think that maybe the blend of all that kind of gave me a unique, I don't know, skill set or mindset to just naturally get attracted to the business of our practice.
And when you started as a medical assistant, when you were,
Mhm.
I guess, having two part-time jobs, one in the hospital setting, one in the clinical setting, what gravitated you toward the clinical side and away from the hospital?
Oh gosh, probably a lot. I mean, of course, the hours. I mean, just the lifestyle's totally different. And I think the more intimate team environment, maybe, and the more one-on-one with the patients. In the hospital, it's a lot, and it's a lot of people, and you quickly become a number. And I just wasn't interested in that environment.
And you are still seeing patients, actually. I'm like, I don't even have time to do my job. And you are the CEO of 17 different locations. So for me, I have no idea how you do it.
Yeah.
How often do you still see patients? And how do
Yeah.
you juggle seeing patients and also the other responsibilities required as the CEO?
Sure. I see patients probably 2 to 4 times a month. So sometimes I'll go a week and I don't see patients if I'm traveling to our other locations or whatever. Um, but I'm able to do it because we have a great team, honestly. We have built a really good, robust leadership team that allows me to be able to do that. And I have been disciplined about keeping that because it's really tempting some weeks to be like, you know what, I can't do this. Like, I'm not going to see patients anymore. Like, the day comes around and you're thinking, this is the last thing I need to be doing. But at the end of every day, I'm so glad I did it. I mean, one, I just love it, and it reminds me of why I do what I do. But you also get to live and breathe all the decisions you're making, and if they're working or they're not working. And I always tell people, because I'll go to our other clinics sometimes and see patients. Like, if you want to get a pulse on the health of the clinic, go see patients for a day there and see how it's working.
Do you
You learn things real quick.
do you test new initiatives or new projects that you're implementing on your core team since you're the
Yeah,
nurse
for
practitioner?
sure. Yeah, for sure.
And what do you find works well for your team? And what have you found you're like, oh my gosh, I'm not implementing this across multiple platforms?
Yeah, some of it is just with workflows, like with charting. I think it's really easy for us to sit behind the computer and say it's with MIPS or some sort of regulation. You're like, oh, we got to put this in and we got to do this. And so it's easy to send an email and say, we need everybody to do this and make sure you do these 2 clicks and do it this way. And then I go do it and I'm like, heck no. Like, we're not doing this. If I don't like doing it one day a week, they're not going to like doing it 5 days a week.
So you get to walk the walk, talk the talk,
Yep.
and figure it out. Do you notice that your team treats you differently than they would another clinician because they know invariably you're the one who has the hatchet or gives them a ladder to climb up?
Yes. I am really thankful though. So the clinic that I'm based out of, so we're in Kansas. We have a lot of really rural areas and we have some more metropolitan areas. And the town I live in is like medium. I mean, it's probably very small compared to what you and maybe some of the listeners think of, but it's a population like 30,000 people. So our clinic that I'm based out of is small. It's, like 2 providers and a core group of nursing staff. And it's where I've worked for 20 plus years. So I'm super thankful that I'm treated like anybody else here. Like they could care less what I do, who I am. Like, they're going to tell me to get in a room and go see the patient, and it doesn't matter. So I very much appreciate that. But when I go to other clinics, that could happen. And sometimes I'll go work as a nurse for a provider. I've been in the nursing role, and I can do that too. And just last month I showed up at a clinic, and I'm like, I'm your nurse for the day. And again, you get to see so much when you just participate in that role for the day.
I think it's really great to be able to have that clinical experience, because when I walk out on the clinical floor and I want to make efficiency adjustments, I get pushback from my team that I don't know what I'm doing because I'm not a clinician
Right.
or I'm not on the clinical team. And at least you get to say, yeah, I've been there, done that. So you get to actually
For
implement
sure.
and have experience and feedback that is beneficial. How would you describe your job? Because I say as a CEO, I negotiate all day long, but yours is like this hybrid thing, even though you may only see patients 4 times a month. But what do you
Yes.
do? Describe your job.
Um, Probably, let's see, how would I describe it? Making sure, I mean, obviously, the overarching priority every day is making sure that all locations and operations are running smoothly and patients are getting taken care of. Like, that's the goal of everything, right? Are patients getting taken care of, and are they getting taken care of well? And if all that's happening, then we get to do the fun stuff, which is mainly strategy and growth. That takes a lot of my time, and that's where I focus a lot of my time on is growth and strategy and recruitment. But then, of course, there's, working with the team and leadership development as far as, um, contract negotiation and credentialing and all the things. But we have a team of people that do that. So yeah, that's
You have to surround yourself around other people to be able to take
right. Like
on
you can't do it all. That's for sure.
for
Or
sure.
you can try to do it all, but you're not going to do it
Well,
very
I always
well.
say I'd rather do a few things really well than try to do everything half-ass.
Yeah,
That's
absolutely.
blunt, but that's how I feel. So
No, it's true.
Heartland Dermatology has been around since before you were born, like the
This is true.
1970s. Yeah. So
Yes.
when you stepped into a leadership role, how many locations were there and how have you expanded upon what you stepped into?
Sure. Sure. So when I first started, we only had two locations, and we were, a small but good, a small, somewhat robust practice. And then when I stepped into the COO role, we had probably 5 to 10 locations. And then we have gradually, in the past 5 years, worked ourselves up to serving 17 locations. And some of those are like outreach satellite clinics because we go to a lot of rural areas. And so maybe some of those locations we're there once a week or twice a week or once a month. And then, a good 8 to 10 of those are full time, like standalone everyday clinics. But we've done that through just organic growth, attracting providers, opening up de novo clinics. But a lot of it's also been through acquisition, with acquiring other independent practices who, either didn't have a succession plan, they were kind of tired of running their own practice and ready for something different. And we've had a lot of opportunity with that as well. And
I
so I've led the practice through some of those acquisitions.
I'd love to understand a little bit of that perspective because
Mhm.
when you acquire another practice, how do you integrate the culture? Or if you have a doctor who has practiced the same way for 20 years and now
Mhm.
you acquire it and the doctor is working for you, that doctor may be used to running the show and now they have to report to you. So, how do
Right.
you work through that transition?
Yeah, it can be hard and challenging. And I think that every time we go through an acquisition, we learn something, that, okay, next time we're going to do it this way. I think it starts by selecting the right partners, right? Like you have to make sure that you're aligned on the front end before you even go through the acquisition. And so if that relationship looks like it's durable and long lasting and you're aligned on, all sorts of things of how you want to practice, how you take care of patients, then you can usually figure it out. But if there's misalignment in the beginning, then it's probably just going to be a train wreck throughout the whole thing. So I think that's one thing that we've done well is we've selected to partner with the right people. And then knowing, I think you have to be careful about not forcing people into your culture. With our geographical spread is, it does create challenges for sure because we're all over the state. And although we like to have our heartland culture, there's all these subcultures within Heartland, right? Like each of your clinics are going to have their own little culture. And so we try to make sure to encourage and foster those subcultures as long as they're aligned with the overarching culture, right?
Have you found that economies of scale has worked for you as you've grown? Because, oh my
Yeah.
God, the cost, I'm sure, in your world has risen dramatically over the last
Mhm.
few years as it has in ours. And that's what I'm looking at. You almost have to grow in order to survive. What is your mentality or your thought process in wanting to grow? Is it just economies of scale or is it something else?
Yeah, I think there's a couple things. We try to be intentional about our growth. Like I've done that a lot recently of stopping and thinking, okay, well, why do we want to grow? Why would we want to acquire this practice? Like, what's the purpose? Making sure that we're intentional about why we're doing something. Um, and I think it can be a few different things. Definitely, economy of scalability brings lots of benefit. And like you said, it's just getting, we could talk all day about how challenging it is to be an independent private practice and how it just continues to get harder and harder and what we're going to have to do to survive, which I think we totally can. But one of that is growing. I think that being a very small independent practice, like, maybe one physician, it's probably possible, but it's going to be really, really hard, right? But I think these medium size private practices can totally thrive. And it is because you have scalability. And so you can get, cost savings on, with how, just volume, you can get better deals and contracts and all the things. But you can start centralizing things and create efficiencies, which is what we're finally kind of to that point in our growth where we're seeing that return of being able to centralize things. If you have all these locations and not everybody has to be in the same spot, and you can centralize support teams or a call center or what have you. And when you have a team that, that's all they're doing is the same task over and over, they get really good at it and they get really efficient at it. And so that brings just overarching efficiencies, which is a big part of trying to survive as a private practice, right?
Do you have one centralized location, like a hub and spoke type model, or do you have various job functions in different locations? Like billing might be in one location, and payroll
Mhm.
might be in another location, and IT support might be in another location, or do you have a corporate center?
It's all over. And that wasn't by design, it's just how it organically happened. Our executive leadership team is spread out. Our bigger size leadership team is spread out. The partners of the practice aren't all in the same location. I'm based in a different location than our HR manager. It's kind of, we're all over the place.
How does that work with communication and spearheading or creating opportunities going forward? I would find that personally very discombobulating, but obviously you've done it right. So what are you doing?
Yeah, it is hard. We live and breathe in teams, to be honest with you, which is a blessing and a curse, right? But teams is what has been able to connect all of Heartland, our staff, our leadership team, everybody, so that we do feel like one, because we have been intentional about, it's really hard to feel like the Heartland when you're one little clinic and you can get really isolated on, well, we're at this clinic and we do this and not understand the bigger picture of Heartland. And so we've tried to do that with teams. And of course, there's, goods and bads with that, and having all sorts of teams chats and virtual calls. But that's how we've done it. And then we really try to we get a lot of windshield time. I mean, I do quite a bit of driving, as do a lot of our other team members. but that's just the way that just comes with the territory of what we do.
That's what I was going to say. 17 locations. So your windshield time, like how often do you visit each location? Do you see them monthly? You obviously can't see them weekly, but what is the
Yeah.
goal for you?
Yeah, for me personally, it just kind of varies. It depends on where the needs are and where I feel like my energy will have the most value. If we do an acquisition and we onboard a new clinic, of course, I'm going to go to that location quite a bit more in those first 6 months as I would somebody else, where maybe we have a legacy location that is high performing and functioning just fine. And I show up and they're like, what are you doing? We're fine, So it's trying to prioritize and understand where you could add the most value.
Are there times when you acquire another location, but then you sunset the physician? I don't know what other way to use to describe it, but
Mhm.
the succession planning we talk about is more of
Yeah.
I will hire a dermatologist who is fresh out of fellowship and place that dermatologist in the location as this person retires? Or is your goal to really have the physician whose practice you acquired stay on?
Yeah, I think our preference in an ideal world would be for them to stay on, because then you have a provider, right? And the patients are familiar with them. If you can keep the providers, if it's the physician, APPs, whoever it is, I think having a familiar face for the patients is really reassuring. You can kind of take the approach with the patients of like, same faces, different names sort of thing. And they have trust that these are still the people that took great care of you. They just happen to be under Heartland Dermatology now. Some of the practices that we've acquired, the physicians haven't stayed on a long time though, because they are looking to retire, and that maybe that's why they wanted to be acquired, is because they didn't have a succession plan and they needed to retire and they need somebody to take care of their patients and their staff. So it kind of just depends on the seller, really, and what their desires and goals are.
Is the succession planning just to take over the patients and staff, or is it also to sell your company for some type of monetary value?
Yeah, both. Yeah,
So they're just
all the
looking
above.
for, yeah, all of the above, just looking for something because they've built up this practice for so long. I don't know what the rules are in Kansas. Can nurse
Mhm.
practitioners work independently?
They can.
So, are there locations where you may just have a nurse practitioner taking care of dermatology needs, or do you have a physician at least at every location?
We definitely have locations where we have nurse practitioners or even just a PA that might be there all by themselves that day. Um, which is not a foreign concept in Kansas by any means, just because we have a lot of rural remote areas. And if APPs didn't go to those areas, those people wouldn't get care. There's just not enough physicians that are going to go to those areas. So it's well received by the communities and the patients. And we have a great physician group who really invest in our APPs. Before you do that, though, you can't. I mean, some of these areas where they are going to be pretty on an island by themselves, they have to feel like it is right. You do right by them by training them. Like it's not fair to them to throw them out into the wild by themselves either if they're not trained, right? And so we have an extensive training program with our physicians to make sure they're prepared to do that. But
What does that training program look like? Because in Florida, it's a really contentious topic. We
Mhm.
have nurse practitioners who work independently, and then you have physicians who say you should not do that, and you can, but under the guise or under the overall umbrella of a physician who's monitoring the nurse practitioner. And
Mhm.
there's so much contention. And every year at the
Sure.
Florida Medical Association, I hear from both sides. But how do you do the training where you feel confident and secure? And you, as a nurse practitioner, this is the perfect question to be able
Sure.
to practice independently.
Yeah, I think if somebody comes to us with no dermatology training, like they're just fresh to derm and don't know anything about derm, and you're not gonna it in the training programs for a PA or nurse practitioner, you're not learning dermatology. I mean,
Hmm.
you might have it like a day or two of it, right? But like you don't know anything. And so it's usually a good 6 to 12 months of training before you're ready to go out on your own. And it's a mixture of they work with some of our long-term, very experienced APPs, and then also with the physicians. And there's some, book review, didactic type stuff, and then just a lot of shadowing. And then we make sure that they're set up and know that they have a resource to call. One beautiful thing about dermatology is that you can take pictures and easily do a phone consult. Hey, look at this. What do you think? And so they're always just a physician's always a phone call away, and we make sure to support that as well. Like even though you can be out there independent, I think that most and some of the contention, people think they're just going to go off and do their own thing, which maybe some will. But I think for the most part, at least speaking for myself as a nurse practitioner, like I don't want to just be by myself. Like I like to be able to call my supervising physician and be like, hey, let's talk this through. And so I think just building that mutual trust, they know that we're going to take good care of patients. And when we need them, we're calling them and they're happy to help. And so it's just about building that relationship.
We're in rheumatology and we do a lot of discussion among each other. The physicians do, the nurse practitioners, the physician assistants, the doctors talk between themselves to try to figure out what the best course of action is for a really difficult patient. And I was just wondering in the dermatology world if that's something that you're also working toward or working with, or maybe it's one day a week or one day a month, or it's just picking up the phone or dealing on Teams, right? How do you handle that?
Yeah, I think there's a lot of collaboration that goes on, and you want to foster that, right? So, like a Teams example, we have a Heartland providers chat group. And so it has all 30 Heartland providers, and we're all in different locations. And some people have maybe never even seen each other if they're new. But we have one of our physicians who does a case of the week. And so he'll put that on there every Wednesday and discuss a case and get some conversation going. But it's also a place where somebody can put something, hey, I got this patient, I'm thinking about this new medication. Has anybody tried it? What's your experience been? And so it's good to have that support system around you.
And you're independent and 17 locations. So I think that is just phenomenal. And it reminds me of a large rheumatology group in Arizona, but they've segued also into Texas. So how do you remain independent? How many owners are there of the 17 location group?
Yeah, so it's just one big corporation. It doesn't, our locations aren't split up or whatever, but currently there's 4 partners. That will continue to grow a little bit. When I was first kind of in the leadership role, we did have just one solo partner and owner, and we have worked to build kind of how that's going to look over the next 15 to 20 years, and getting other partners on board and kind of getting his succession plan in place as well. And I think that partnership is a really big piece of staying independent. Like that is our competitive edge, right? Against some of these large hospital systems or even private equity, which I think there's a place for everybody and they all have their pros and cons, but it's not one thing is for everybody. And so having options is good. And I think the big competitive advantage that we have, your practice, our practice, is partnership. I mean, who else is offering that?
Well, I was going to say we can offer it, but we actually don't have any partners right now.
Mm-hmm.
And you only have 4. And how many doctors are there?
7 right now. We have 2 more joining next year. I mean, I think that partnership is gonna get up to 7 or so pretty quick, gradually.
And what does your partnership track look like? How do you decide that somebody is set for partnership? Is it something that you start with at the very beginning before you even sign a contract? Yeah. Share that experience or share that outline with me.
Mm-hmm. Yeah, when I'm recruiting a physician, it's one of the first questions that if they don't bring up, I bring up. Like, what is your desire for partnership? Because it might not be for everybody, and that's okay too. Some people just don't want anything to do with it. They want to come and they want to see their patients and they want to go home, and that's all they want to do, and that's totally fine. But it's also very attractive when they do want to be a partner, because that means they're going to be invested, and that's something sticky, and they're going to stay around and they're going to care, and it's longevity, right? And so partnership for us looks like usually a couple years. You want to make sure that they're a good fit. You want to make sure that you're a good fit for them. You don't want to, you have to have a little bit of a dating period, so to say, to make sure that it's going to be good long term. And then there's a buy-in involved. Sometimes we'll use equity grants as part of recruitment. Maybe instead of a sign-on bonus, you give an equity grant, and then they can use the distributions from that equity grant to maybe fund future purchases for buy-ins. So it can look a little different ways, but they buy in because they're getting an asset out of it.
That's really interesting, the equity grant. Can you elaborate on that and explain how that works?
Yeah. Have to be careful because I'm not an accountant or an attorney, so I don't want to misspeak. So don't take anything what I say as Bible here. But it's basically, you still have to treat it as compensation because it is something of value that you're giving somebody. And so there is a whole tax event that has to happen with it. So there's different ways to get around that because you also don't want, a situation where you're like, here's a really pretty present. And then they get a big tax bill and they're like, wow, thanks, And so there's different ways you can structure that and help cover some of that tax implication. But that's what it is. I mean, it's a gift of value, really.
I think that's a really interesting perspective, and it's a different way of looking at it. And I know even being a part of the CEO Summit at MGMA, I've learned a lot of different ideas about how to structure partnership. What
Yeah.
I'm finding now is we're in the process of recruiting and onboarding more rheumatologists, and everybody asks about partnership, especially
Right.
those who are finishing fellowship. And I think it's difficult to know something that you have no experience about yet.
Yeah.
And I say that because everybody wants partnership. Oftentimes it's thought that it will be just handed to them because they've worked
Yeah.
2, 3, or 4 years, or they think that showing up and taking care of their patients constitutes partnership. And there's a lot of work. I mean, this is my 4th child. Literally, the Hirsh Center is my 4th child. I live
Right.
and breathe it. I think about it
Right.
all of the time. People are like, "Oh, did you enjoy your vacation?" And
Mhm.
I'm always thinking about work, like I am with my children. And I do have to check in and I do have to do certain responsibilities. It's not a true vacation. I don't clock in and clock out. And from a doctor perspective, yeah, you can't just see your patients and think, okay, I've worked, now I get partnership. So, how do you
Right.
explain partnership to the newer physicians or those who aren't yet partners when they join Heartland Dermatology?
Right. I think some of the conversation starters that I use is, why do you want to be a partner? Like understanding why they think they want to be a partner. Is it because you want the value of it and you're looking for distributions and you want to like build wealth? Or is it because you want to have voting power and a voice? Like why do you want it? And you can get all of those things is usually the answer, right? But having them understand that the whole buy-in thing is because you're getting an asset. Like this is worth something, and I usually show, we do evaluation. We have a formal valuation through the accountants that, shows what is this worth. And if you get 1% of something, like this is worth something, just like you would buy, like you don't just go to the stock market and just get shares. Like you have to buy them, right? But you have something to show for that. And having them understand the entry and the exit. So like you buy in, but like once you have this, and the whole goal is that you bought it for this amount and we grow and we're a healthy practice. And in 10 years, it's worth this much, right? And so then now you have an asset that is hopefully appreciated. And when you go to then exit at the end of your career, hopefully then it's worth something and you've built value and wealth and you've got a return on your investment. And so that's usually how I like to explain it. And and I usually will do some sort of ROI for them, because we distribute almost all of the profits. We don't have a lot of retained earnings. We like to distribute the profits out to the partners. So then they can use those distributions to either reinvest and buy more shares or whatever they want to do. Um, and so I usually try to put that together for them too, because they have no idea. Like, okay, well, it costs this much, but what am I going to get? You know? And so you have to go through the whole song and dance of like, these are our earnings. This is what we distribute. This is what it's going to cost. It's going to take you this long to, regain your investment, et cetera.
So are you structured as a C Corp?
We're an S Corp.
Oh, you are an S Corp. So
Mhm.
so you distribute all the earnings. Everybody has their own S Corp, I guess the 4 partners. Is it divided up where everybody has 25%? Because you had mentioned some people may only have 1% or 2%,
Right.
but everything is worth a value. How do you structure that?
Yeah, it's definitely not equal as far as percentages. We have, we started with a solo owner, and so what's worked well for us, and again, I think every practice is going to be different on how this design works for them. But what worked for us is we had this one partner who was ready to bring on additional partners, and I think he had choices, right? Like he had built this practice for 20 plus years, and it had huge value. And of course, he could go to private equity and get X amount of dollars. And I'm sure that looked really attractive, as he should. Like he spent tons of, just as it's your fourth child. It was his fourth child. And he should get something from that. But also knew that that wasn't the dance that he wanted to do. That's not the track that he wanted to do. But you still should get value for what you've built. And so how we've kind of designed it is these new partners are actually buying shares from him. And so when somebody comes in and they're buying equity at this point, which maybe we'll get to this point at some point, but they're not just buying shares and then diluting everybody. They're actually buying equity from the majority partner. And so as he kind of goes down in equity stake, they're going up. And so it's kind of been this gradual shift.
So
But so not everybody's the same.
yeah, that's great. So to figure out what the company is worth, how often do you do a valuation of the company?
So we were doing them kind of just sporadically whenever we thought that we had an event that triggered a valuation. If we acquired another practice, if we recruited a bunch of physicians, something that would, change what our value was, I guess. But actually, just this year, we worked with the accountants to go through a new valuation to set it up that's a little bit more self-sustaining, to create a formula that it's more plug and play. So we've gone through all this work this year that next year we can just update numbers and it spits out something new, and we don't have to go through this whole, valuation with a third party. So we're going to trigger that every year now.
When you do a valuation, is it based on EBITDA and a factor of that? Or how do you actually create a valuation when there are 4 partners within a larger entity?
Yeah, they're just valuing the actual entity, right? And so, these accounting finance people that are way smarter than me know how to do it. And I think that, there's different ways that you can do evaluation as far as, assets and cash flow and EBITDA and all of that. But essentially, it's an adjusted EBITDA, and then it's a multiple of that. And then, it says it's worth X amount. And so then if you're going to buy 1%, it's 1% of the X amount. That's your cost.
What do you think has been the most difficult challenge in staying independent right now? Because
Mhm.
you're in dermatology. My brother's a dermatologist and he's still independent, but there are not a lot of you guys left. And so what are you finding as the biggest challenge? And I would say specifically in the world of dermatology.
Sure. Probably the cost reimbursement squeeze. I mean, we're all very familiar with the fact that the cost of business just sharply goes up continually, and CMS fee schedule goes down. Like that just is getting narrow and more narrow and more narrow, and it's making it more difficult. It's it's terrible. I mean, you know it. This is nothing new. So that's the biggest thing for sure. And then just the administrative burden, everything that changes. I mean, you live in the biologic chaos as we do as well. I mean, these prior auths and the MIPS and the value, it's a little bit out of control.
It is so out of control. So I am going to wrap up and ask you my final question because this is a perfect segue. With
Sure.
all of the madness, what is the one thing that you would create change in within our American healthcare system to try to fix this madness?
I would say I would really love a world in which we normalize. It's really easy for you and I to talk about this, but I think just in reality, it's not normal. But to normalize talking about the business of healthcare, like we tend to live in a very binary world anyways, where it's like one or the other. And I think that overflows into healthcare or medicine as far as people are binary of you either care for patients or you care about the bottom line. And it's like, if you talk about margin or business strategy or finances, you don't care about patients. And the reality is that both things can be true at the same time. And I think that's what we're going to have to do. I mean, we need, it really behooves employees to care that their employers care about the bottom line. Patients should want us to care about the bottom line. Like that a healthy business can invest in good people. It can invest in technology for the patients. It can make sure that these rural communities are served. But it tends to be a little taboo. I don't know if you've experienced
Oh
that
my
or
God,
not.
Tara, you're the nurse practitioner and the CEO. I'm just the CEO. So do I experience it? Oh my gosh, probably
Yeah, I
at a
did, yeah.
magnitude of you.
But we have to talk about it.
Oh,
or we're not going to
100%.
come up with solutions, and we're not going to have this revival of independent practice that we're all looking for. And so I guess my wish would be that it's not taboo, but it's actually responsible.
I love what you said. I'm smiling here for those who are just listening to the podcast and not seeing it on YouTube, because you are the only person who has ever said this response in my entirety of having working healthcare as a podcast. And I think it is so phenomenal to say that because I was in a meeting just last week and I said something similar. You said it more eloquently than I did. But if we don't exist, how is that good for patients?
Right. Exactly. Like I think that independent practices have so much to offer. And again, all the other designs and health systems and private equity, I mean, they have stuff to offer too, but we have a unique thing to offer. And I think communities and patients and employees should want that. And the only way we're going to do that is if we do have healthy businesses. And the only way to have a healthy business is to talk about it, right? But coming from the clinical side, I see that. I'm sure that at one point in my career, I thought, wow, all they care about is the money. They don't care about the patient. And it's not the case. And I'm sure there's people out there that do, but that's not the case.
That's perfect. So on that, I'm ending it because it is very well said. So Tara Gillespie, thank you for joining me on Working Healthcare. If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsh.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.